Good morning.
Good morning.
At this time, please begin the live stream of this meeting. The education, I'm sorry. Okay. All right. Education and Practice Committee of the North Carolina Board of Nursing will now convene quorum for the meeting. This is an official meeting of the Board of Nursing in accordance with North Carolina's Open Meetings Law under Article 33C, Chapter 143 of the North Carolina General Statutes. The board recognizes the public's right to attend and observe this meeting. As such, this meeting is being streamed on the board's YouTube channel as well as being recorded. The board's mission, vision, and values drive our work as a committee and serve as a reminder to us as we carry out our business. The mission of the board is to protect the public by regulating the practice of nursing. Our vision is exemplary nursing care for all. In pursuit of our mission and vision, we focus on three core values: equity, where we are committed to fairness and justice; integrity, we act in good faith in protecting the public; and agility, we are responsive to emerging healthcare trends. In accordance with the State Ethics Act and the Code of Conduct for members of the North Carolina Board of Nursing, it is the duty of every member to avoid both conflicts of interest and appearances of conflict. Does any member have any known conflict of interest or appearance of conflict with respect to any matters coming before the board today? If so, please identify the conflict or appearance of conflict and refrain from any undue participation in the particular matter involved. Seeing none, I would like to welcome all of our committee members, and I would also like our committee members and staff sitting at the table to introduce themselves. And we will start at my far right.
I'm Dr. Carmen Shaw, and I'm a board member.
Dr. Amy Steele, board member.
Meredith Parrish, Chief Legal Officer and Board Staff.
Dr. Crystal Tillman, Chief Executive Officer.
Dr. Raquel Ingram, North Carolina Board of Nursing Chair and Chair of Education and Practice Committee.
Stacy Thompson, Practice Consultant.
Good morning, Dr. Sarah Griffith, Chief Nursing Officer.
Good morning, Andrea Jepson, board member.
Good morning, Dr. Kissler, board member.
Dr. Jenna Caparel, Nurse Regulation Consultant.
Paulette Hampton, Practice Coordinator.
Thank you so much, committee members and staff. I would also like to welcome our guests who are observing today, both here in the board room and online. Are there any announcements at this time? Seeing none, committee members and staff, the meeting agenda is provided in the meeting book. Are there any additions, modifications, or reordering requested at this time? Seeing none, do I have a motion regarding adoption of the meeting agenda? Thank you.
I move to adopt the meeting agenda for today.
Thank you, Dr. Steele. Dr. Steele has moved to adopt the meeting agenda. Do I have a second?
Second.
It has been seconded by Sandra Lewis. I will now call for the vote. All in favor by show of hands, and the vote is unanimous. The meeting agenda is adopted. Now for approval of our minutes from our August 20th, 2025 Education and Practice Committee meeting. Those minutes are provided in the meeting notebook or the meeting book. Are there any additions or modifications requested at this time? Seeing none, do I have a motion regarding adoption of the meeting minutes?
I move to adopt the meeting minutes from August 20th, 2025.
Thank you, Dr. Steele. Dr. Steele has made a motion or moved to adopt the meeting minutes. Do I have a second?
Madam Chair, I'll second.
Thank you. It has been seconded by Andrea Jepson. I will now call for the vote. All in favor by show of hands, and the vote is unanimous. The minutes have been adopted. Now for open comment period. We are now at the open comment period portion of the agenda. The purpose of open comment period is to provide members of the public an opportunity to share their concerns, offer views, and present questions regarding issues that impact nursing and nursing regulation. At this time, we have no requests to speak during open comment period. Therefore, we will move to the next agenda item. Agenda item 4, so the role of the medication aid is what we will talk about today or discuss today. The purpose of our Education and Practice Committee is to support the work of the board, to review matters related to education and practice, and to make recommendations to the board as charged. In January 2025, the Board of Nursing approved the charge for the Education and Practice Committee to provide education on the law review and the administrative code of rules and explore best practices related to the medication aid role that may include recommendations for revisions to the rules to the board. Following board staff presentations at the August meeting, the committee focused on 4 points during that time: performing an assessment of the need for 3 categories of instructors, obtaining workforce predictions related to faculty and medication aids, clarifying the terms adult care setting, medication aid, and medication technician, and leading in the creating of knowledge. Practice staff have gathered materials and invited guests based on the discussion in the August meeting to provide additional information on the role of medication aid. The committee will use information from the August meeting and today's meeting to assist with decision-making for next steps related to this topic. Stacy Thompson will walk the committee through the materials and information in our meeting book. As we walk through the information, we will hear the presentation and summary of key points and issues. And I will now turn the discussion over to Stacy Thompson.
Thank you, Madam Chair. In January of 2025, the board charged the Education and Practice Committee to provide education on the law, review the administrative code rules, and explore best practices related to the medication aid role, which may include recommendations for revisions to the board. At the committee meeting held on August 20th, 2025, board staff presented information and applicable research related to the role of the medication aid to the Education and Practice Committee members for review. Board staff created a resource meeting book and provided summaries of important points. Resources specific to the presented content are located in the onboard application, and you click on the Resources tab in the left toolbar. Once you click on Resources, then you'll choose Education and Practice Committee, and then the role of the medication aid. And in that folder, you have access to the 12 articles that were provided in the literature review, in addition to 7 resources that were reviewed from the National Council of State Boards of Nursing, or NCSBN. Resources for today's meeting are provided both in onboard within the agenda, as well as a printed notebook at your seat that has an agenda and handouts for each section that we'll discuss today. Slides will also be shared as we progress through the agenda for in-person and online guests. Please note that the slides may appear slightly different from your meeting book. However, the titles and tables of information, as well as the page number within the meeting book, will be referenced for clarity. The page numbers for the meeting book are located in the bottom right-hand corner of each printed page, or by hovering at the bottom of the page in onboard. Are there any questions about resources before we move on? Okay. We have the okay, a summary of activities of the August 20th, 2025 meeting will now be provided for each section that was involved in the discussion. We first discussed the development of the advisory committee. Background information was provided related to the development of the Medication Advisory Committee in 2002 to develop legislation, to develop training requirements, and a curriculum for the role of the medication aid. Actions from 2003 to 2010 by the Medication Advisory Committee included a development of a position statement, rule revisions to establish the prerequisite of high school diploma or GED for medication aid training and listing on the MedAid registry. 3 levels of faculty for medication aid training programs were established, which include the medication aid instructor, the master teacher, and the chief educator. Medication aids were approved to practice in skilled nursing facilities in Senate Bill 622 in August 2005 and became effective July 1st, 2006. Curriculum revisions to the student and instructor manuals were approved, May 14th, 2010. Information also included differentiating between a medication aid specific to nursing homes and medication technicians specific to adult care settings. The adult care settings include group homes and assisted living facilities. These two roles obtain initial education and training specific to the practice setting in which they will work and are governed by different entities. To review the differences, please refer to Table 1 in the summary tables and information attachment in Agenda Item Number 4, which is on page 6 of the meeting book. Table 1 compares the medication aid in nursing homes to the medication technician in assisted living facilities and group homes. The medication aid is specific to nursing homes and is regulated by the Board of Nursing. Medication aids in nursing homes administer medications through the delegation process by a licensed nurse after completing the board-approved training. Medication technicians work specifically in adult assisted living and group homes, facility licensed through the Division of Health Service Regulation, or DHSR. These settings may or may not require a licensed nurse on site. The Board of Nursing has no jurisdiction over the medication technician and group homes. Again, the training for the medication aid and the medication technician is determined by the setting in which they will work. So understanding these differences helps to charge of reviewing the role of the medication aid in nursing homes pursuant to the Board of Nursing's jurisdiction. The summary jurisdiction section of the document on page 6 of the meeting book is entitled of Medication Aid in Nursing Homes. This section depicts the Board of Nursing's jurisdiction related to the medication aid in nursing homes to include the delegation by medication aid faculty requirements, medication aid applicant requirements, and medication aid training programs and education materials. The Board of Nursing does not have jurisdiction over the specific facilities where medication aids function, as DHSR provides license. After establishing the jurisdiction specific to the current charge, medication aid faculty requirements for each of the 3 levels of faculty were reviewed. The current requirements for RN instructors includes having an active RN license, 2 years of practice experience in that includes medication administration, completing a board-approved instructor training program, maintaining board certification as a medication aid instructor, and renewing every 2 years, given that the instructor has taught at least course within the preceding 2 years, in addition to program changes approved by the board. Information related to the development and composition of the medication aid last meeting, the medication aid curriculum and research developed during the collaboration with DHSR during the work of the Medication Aid Advisory Committee. Resources provided to facilitate the curriculum include a student manual that was last revised in 2010, the instructor manual, which was also revised, a DVD, which is a 70-minute video to read manuals, a toolbox supply information that was revised last in 2017, and a medication administration record. These were last revised over 12 years ago, with no revisions documented for the DVD and the medication administration record since they were initially. Next, at our last meeting, the NCSBN Model Act and Rules were presented. Surveys and articles were also provided by and were summarized to provide an analysis of knowledge related to the role of the medication aid. These were not specific to the nursing home setting, but provided basic descriptions of activities that are performed by medication aids. Focus was given to the resource of Model Act and rules specific to instructor qualifications. NCSBN's Model Act and rules provide an network of nursing statutes and regulations for state boards to use during policy and advocacy discussions, such as the current charge of the committee. The Model Nursing Practice Act and Model Nursing funds for faculty qualifications for the Nurse Aid 2 and Medication Aid courses, and can be the example to follow for state boards of nursing. The section entitled NCSBN Model Act and Rules Instructor Qualifications on page 6 of your meeting book provides a summary of this information. Rules require an instructor to have an active license to practice in the state, have a minimum of 2 years practice experience in a healthcare facility, at least 1 year of clinical experience to the area of responsibility, and in this case would be medication administration. Documented evidence of preparation for teaching adults, periodic training updates. A more detailed comparison is now provided between the Model Act and Rules of Instructor Requirements, Board of Nursing Instructor 2 on page 7 of the meeting book. The differences are shown in red and indicate the Board of Nursing requirements as more requiring completion of a board-approved training program, doing the instructor's approval every 2 years, only after teaching the course at least once in the 2-year period. The Model Act and rules do not have these, but do require documented evidence of preparation for teaching adults. North Carolina general statutes and administrative code rules were summarized in the August meeting to establish the requirements and regulation of the medication aid role in nursing homes. The governance components section, beginning on page 7, provides each of these components for reference, and key points of consideration are highlighted within the document for focused discussion. So the first component is General Statute 90-171.56, medication aid requirements. This statute provides the Board of Nursing standards for faculty and applicant requirements for ongoing review and evaluation, and recommend change and med aid training requirements to support safe medication administration and improve client, resident, and patient outcomes. So this statute is the current charge. The second component is General E-114.2, entitled Use of Medication Aids to Perform Technical Aspects of Medication Administration. This statute allows licensed facilities to utilize medication aids to perform the technical tasks or technical aspects of medication administration consistent with the Nursing Practice Act. The statute requires a medical facility to be listed on the NA1 and also listed on the medication aid registry, and prohibits IV and injectable medication services. Administrative code rules pertaining to both the Board of Nursing and service regulation provide regulation requirements related to the role of medication aid. Rules specific to the Board of Nursing's jurisdiction include 21 NCAC 36.0221 entitled License Required. This rule protects the title. It also provides criteria for delegated tasks. If are not met, the task shall be performed by a licensed nurse. And it provides activities that shall not be delegated related to professional judgment. So things like recognizing side effects, toxic effects, allergic reactions, immediate desired effects, unusual and unexpected effects, or changes in a client's condition that contribute to the pharmaceutical or treatment regimen. Prohibits the delegation of anticipating effects or making judgments and decisions concerning actions to take in the event such effects occur. The next rule is 21 NCAC 6.0406 entitled Medication Aid Training Requirements. This rule provides the faculty requirements and active unencumbered license to practice as an RN, 2 years of practice experience as an RN that includes medication administration, successful completion of an instructor training program approved by the board, and maintaining the board certification as a Med-Aid instructor, renewing it every 2 years. This rule also requires an applicant training program to have a high school diploma or a high school equivalency. So key points for consideration from the governance components review include that the Board of Nursing jurisdiction includes faculty requirements, applicant requirements to support safe medication administration in nursing homes. A nurse may delegate the technical task of medication administration, which includes the 6 rights of medication administration. Medications are not to be delegated to medication, and tasks requiring judgment and decision-making must be performed by a licensed nurse. The rule does include a specific faculty requirements for medication aid instruction. The current position statement is entitled Medication Aid Education and Role in Long-Term Skilled Nursing Facilities versus Adult Care Settings. So a copy of the position statement is included under agenda item number 4, and it begins of the meeting book. Areas of the document are also highlighted for focus points of discussion. The position statement first provides information specific to the RN and the LPN role in delegation and oversight of the medication aid. The nurse may delegate the technical aspects of medication administration to the Med-Aid, which includes the 6 rights of medication administration. All ongoing assessments, interpretations, and decision-making must be carried out by the licensed nurse and not be delegated to the medication aid. Specific judgments are listed and may not be delegated, such as what we just read out. The position statement brings together information from nursing law, from rules, and DHSR requirements to differentiate between the Med-Aid in long-term care and the Med-Tech in the adult care setting. Long-term care settings include nursing homes and skilled nursing facilities. Adult care settings include assisted living facilities and group homes. The position statement addresses the medication aid's role for training for both long-term care and adult care, and the listing requirements and employer responsibilities for each role were also addressed before providing contact information for the appropriate entity. In addition to this information, a table is provided on page 14 of the meeting book or page 5 of the position statement to list approved medication aid activities for each type and includes the routes of medication administration that are allowed in each setting after appropriate education training. Finally, the position statement a continuum of care flowchart of medication administration, emphasizing the role of the medication aid being limited to the technical task of administration, which includes the 6 rights. This chart is also shown as the last attachment under agenda item 4 and on page 17 of the meeting book to highlight important points. Within this framework and consistent with Rule 21 NCAC 36.0221, the actual task of giving medications is considered a technical activity that does not require the professional judgment of a nurse. And it's circled in red in your meeting book, and it's highlighted in yellow on this slide. Thus, the performance of this technical task may be delegated to an appropriately qualified medication aid. However, all ongoing assessments, interpretation, and decision-making required relative to the client's receiving medication must be carried out by the nurse. The nurse is deciding when to administer PRN medications, and also deciding when to withhold a medication. A review of literature related to the role of medication aid revealed a focus on educating licensed nurses on the responsibilities of supervision in the delegation process. Current literature is limited in addressing the effectiveness of delegation from a licensed nurse to a medication aid related to supervision and patient outcomes, in addition to influence the delegation process and impact service and patient care. No literature was identified providing information on instructor requirements or credentials. Future research opportunities include exploring delegation and supervision by the licensed nurse to determine the impact on patient outcomes and how organizations to the decision of delegation by the licensed nurse. Budin 2011 encourages regulators to educate long-term care administrators about the role and responsibilities of the medication aid to increase knowledge of how this role functions within the organization. In addition, education related to the licensed nurse's role in supervising the medication administration by medication aids in the long-term care setting is suggested. The review and comparison of rules in other states revealed that there are states with more lenient faculty requirements than North Carolina, and there are also some states with more specific requirements than North Carolina. Following board staff presentations, committee members information provided and focused on 4 points. The first being the need to perform an assessment of the need of 3 categories of instructors, obtaining workforce predictions related to faculty and medication aids, clarifying terms such as adult care setting, medication aid, medication technician, and leading in the creation of knowledge. Information to be provided for today's meeting will focus on the following. First, we will hear provided by the Division of Health Service Regulation. We'll have comments from representatives who are here in person. We'll hear a presentation of a survey that was distributed to medication aid instructors. We'll hear about a review of the current curriculum, and then finally, a summary and development of next steps. This activities from the August 20th, 2025 meeting that provide information on the role of the medication aid in nursing homes.
Thank you, Stacy. That was an excellent summary of all of those activities from that time frame. Are there any questions for Stacy regarding the summary of activities? Right, seeing none, Stacy will now provide a presentation of information from the Division of Health Services Regulation, or DHSR.
A summary of key points for this section located on page 18 of the meeting book. So during an interview with Jamie Johnson, who is the Assistant Section Chief for the Healthcare Personnel Education and Credentialing section at Health Service Regulation, the jurisdiction of the medication aid in nursing homes was discussed. So DHSR established maintains the medication aid registry for all who complete the course. Also for state administered competency exam and listing A1 registry. Renewals are completed on the healthcare personnel website every 2 years and require an RN to verify at least 8 hours in the registry period as a medication aid. The HSR administers and evaluates the competency exam using the Credentia platform for administration. And the current data that is collected is limited to the statutory authority, which includes the MedAid's name, the listing number, expiration date, and the completion of the RN verification of employment. No other data related to this workforce is currently collected. And this concludes the information on HSR.
Thank you, Stacy. Are there any questions related to the information Stacy provided about DHSR? Stacy, for clarity, you said every 2 years in terms of renewal and have worked at least 8 hours within that 2-year time frame
As a medication aid.
as a medication aid. Yes. Dr. Gissing.
Yes, just one other clarifying point, and you may not be able to answer. They also have to maintain their NA1. So are they looking that they've done the 8 hours required within the 2 years within the role of the NA as well?
They have to be listed on the NA1 registry before they can apply for renewal as a med aid. So it's two separates. So they have, their NA1 has to be current before they can renew their med aid. And the med aid is specific to 8 hours working as a med aid.
Thank you.
And one more question, Stacy. Administer the state competency exam. Who administers?
So DHSR
DHSR.
administers that exam through the Credentia platform.
Yes, okay, all right. Any other questions for Stacy? Okay, all righty. We will continue now moving forward with representative comments. So we have representatives from 3 nursing homes present with us today to provide comments related to the current charge. And each representative will have 10 minutes to provide comments, and then the committee will have the opportunity to pose questions related to these comments. So I'll now turn it back over to Stacy Thompson for the presentation of introductory information for the speakers.
Thank you, Madam Chair. Registered nurses in various roles have agreed to provide comments to the committee related to the role of medication aid in nursing homes. I'd really like to thank Eric Cavisto, who is the Executive Director of Future Care of North Carolina and Director of Quality Improvement Projects with the North Carolina Healthcare Facilities Association, and also Clarice Briggs, who is the Director of Compliance and Risk Management with Kentura. Both of them were of great assistance in identifying speakers who would be available to share comment today. Each speaker will have 10 minutes, and you can reference the talking points for each representative in your meeting book. One document had been pending when the book was made available to you, and that document was uploaded this morning. So there will be the last talking points have been added for your review. It's also in your notebook as well. The questions posed to the speakers are provided under agenda item number 6 on page 19 of your meeting book. The questions focus on the board's jurisdiction of faculty requirements, applicant requirements, and training and education materials. The 3 questions that will be addressed, first one is, what competencies or clinical skills do you consider essential for medication aids before performing the technical task of medication administration in long-term care? Number 2, how does your facility ensure ongoing support and supervision for medication aids after their initial training for things like skills checkoff, continuing education, or delegation? And lastly, what is the biggest challenge medication aids facing from classroom training to real-world medication administration? How do you help overcome these? So our first speaker is Garrett Saki. He is the administrator at Sandstone Camden in Greensboro, North Carolina. So I'd like to welcome Garrett to the.
Good morning. This is my first time here. Thanks for having me. Am I good? All right. Well, again, my name is Garrett Saki. I'm from Camden Health and Rehab in Greensboro. I've been a long-term care administrator for about 12 years now, and have worked in CCRCs and currently skilled nursing homes. I'm also a registered CNA as well. Throughout the time in healthcare leadership, we've seen the role of the med aids evolve. And I think there are some pros and cons in the evolution of that process. as was discussed earlier, it was initially intended to handle that technical aspect of the medication administration. I think the reality of the world is that it's evolved to be almost like an assistant nurse at this point, where they're not overstepping their scope, but really reaching the limits of that. In my facility, we're 135 beds. I consider us kind of a medium to medium large size facility in North Carolina. So you can picture a little bit what's happening on the floor. Our building's broken up into 4 units. And on each unit, it's staffed with CNAs, a nurse, and a medication aide. The med aides work on first and second shift for us. There's not a need for them on third shift. The nurse is perfectly capable of handling that load on their own overnight. And we've been utilizing med aides in our building since 2018. So not a super long time, but pretty long enough to have ample experience with them and to kind of see the evolution of it. Why we chose to start using medication aides is it's a great opportunity for promotion from within your staff. We have an abundance of CNAs. They want to grow. This is a first great opportunity to do that for them, to grow their skill sets, to advance in their careers, often a stepping stone on the way to become nurses. And from the business standpoint, it is an affordable option. I would love to staff each of my units with 2 nurses, but it's just not feasible, both from an abundance of nurse standpoint and also the cost of nurse standpoint. The med aides are a great compromise in that process. Kind of the opposite side of why the cons of using the med aides, they're limited in their scope, obviously, and that's a big limiter for us. We would love to see 2 nurses splitting a unit and being able to assess and handle all of that. In reality, in all of the facilities I'm aware of, that medication aide is acting like a nurse assistant in the fact that they are carrying out a lot of the nursing duties minus the assessments. They're really pushing the boundaries of that because there's not a second nurse present at all time. Their training, however, the med aides training, however, is coming from a CNA, and a lot of the time they identify as a CNA more than a nurse, which is appropriate, but in the real world tend to work down to the CNA level as opposed to up to the nurse level. They see themselves quite limited. Some of our observations in their training, our med aides tend to come to us with that very basic knowledge of the 6 rights of medication administration. We then take over the role of training them what it truly is to be a med aide. We find that a lot of folks still don't know the difference between generics and brand names. Had the experience just the other day that said Tylenol versus acetaminophen, even something that seemed would be pretty understandable was hard to understand. And then you get to less familiar ones, Ativan and lorazepam. Well, they're the same thing, but they're called different things, right? And so it causes a lot of hesitation, a lot of misunderstanding their potential. The training program is very short. It's 3 days in most cases, which is a pro and a con, right? People are very incentivized to do it. It's three full days of training, and I can med aid. I can make more money. I can have more responsibility. That's great. From the administrator standpoint, we go, there's only 3 days of training. Oh, okay. And now you're going to now you got a med cart. Holy moly. It feels very overwhelming. And so we spend in the facility an additional 12 shifts of training with a nurse for us to consider. It's significant. And it would be recommended by us to consider expanding that training program while still making it approachable and an incentive for people to do the training program. It feels very short. Things such as the med aides need that reinforcement all the time of what are those 6 rights of medication administration. They don't have that drilled into their blood by the end of 3 days. So while yes, we do our annual assessment to basically recheck them off every year, it's a weekly and daily assessment to do that, which is appropriate in the building to maintain the quality of care that we are looking for, but is also something that could be supported through the education and the credentialing program as well. I think if there was an aspect of the credential of the education program that we would want more enhancement of, it would be the pharmaceutical knowledge, how things, while the med aid is not doing the assessments, they are interacting with our residents and the medications and witnessing them, just as we would expect a CNA to report changes in behavior, reactions to things. A greater knowledge of pharmaceutical side effects, their intended uses, and vital sign, what to recognize in vital signs would be really beneficial. We're finding ourselves doing that training. I think it would be a really beneficial part of the education program. Also, something we focus on with medication aides and nurses in all stages of their careers is proper medication storage. It's something that's really, really important. Feels like it's never a process that is finished in education. Like I said, we review that with nurses at all stages of their careers. I think the boundaries of injectables and IVs is appropriate. When I polled my nursing staff on, do you think that it would be great? And they all said unanimously, no. The assessments involved in that are a lot more, and it's important for the licensed staff to maintain that, and they really supported that. I'm not a nurse, so I wanted to seek their input, and they clearly felt that that should remain the case. The hazy part, I think, in the real world comes when someone has PRN medications. That's where things get tricky. That resident is asking for pain medication, and the nurse is responsible for assessing and saying if it's appropriate or not, and balancing that with the demands on the nurse and the med aid at that time are where we tend to we don't want to cause delays in medication administration, but that is certainly an obstacle for us to overcome, is the use of PRN medication. I think the med aids are a great asset to our facility. However, it poses a lot of restrictions and restraints on what they're able to do. And if you're going to do it right, they do not relieve a lot of the staffing needs that I think are intended to have by medication aids. And also, I think DHSR and DHHS should work with CMS to incentivize facilities to use med aids more. From a staffing star point of view, they do not help us. They are CNAs. I think having a category of med aid or counting them, I don't know if you can count them in the staffing star world as half a nurse, some type of compromise there to incentivize facilities to use them would go a long way. And I think a recommendation from the board to DHSR or DHHS would go a long way as well. To ultimately that goes up to CMS for decision. That's my comments for today. If there are any questions, I'd be happy to answer them.
I have a question. You mentioned it twice. You said that, CNAs are working, the medication aid is working down to the CNA level and not working up to the nurse level. So can you explain that a little bit more when you say, I understand working as a CNA, but because they are, but what do you mean when you say working up to the nurse level?
I think of it very much as a cultural expectation that you have progressed and been promoted up to a medication aid, and you're sitting there in between a nurse and a CNA, and you are going to carry yourself and hold yourself to standards that are appropriate for your position. It's much akin to dress for the job you want, not for the job you have. How are you going to carry yourself in the facility? How are you going to hold yourself to the highest possible standard? And there is no doubt that there's a difference between a nurse and a CNA in the way that they are carried, that they carry themselves throughout any facility, and the standards they hold themselves to. While we hold them all at a very standard, their personal expectations vary.
So it's more of a professionalism thing than scope to a
Absolutely, yeah.
nursing level.
Yes, a
I just wanna
professional,
clarify
not a
that.
scope. I don't think the scope,
Okay.
I do think the scope is appropriate,
Okay.
correct? Yeah.
Any additional questions? Yes, go ahead.
Right. Is your facility rural, or what describe the setting, this facility that you're speaking of?
We're in the middle of the city of Greensboro, so we are,
Okay.
I would not call us rural.
Okay.
We're pretty busy. It's a high churn building is the way I describe it. We have a lot of short-term rehab. Our census turns over frequently,
Mhm.
about 60% short-term, 40% long-term.
Thank you. And then one other question, just for my own knowledge, I'm trying to visualize. So when a medication aide comes to work, they are assigned to be the medication aide that particular shift,
That's
not,
correct.
they're going to be a CNA one day on a shift, or a medication aide on a shift. Is that how they're assigned?
That's correct. They're assigned as a medication aid. There is certainly an expectation that if there is a need for CNAs, that they will be pulled to that CNA role. Ideally, everybody shows up to work and everybody's operating as expected, and that's not required, but is definitely an expectation that they would be pulled into the CNA role if needed.
Do y'all look at that as two job positions
Yes.
in the setting? Just always worry about, regulatory people coming in and, are we talking, in this medication aid is supposed to be a medication aid, but they actually were doing CNA work for whatever and
They-
transition?
They are separate positions.
okay.
In our staffing reporting, we report nurses, med aides, and CNAs separately.
Thank you.
Yeah.
So note, when your med aid is operating as the med aid, and there is a need for a resident, is that med aid expected to attend to that resident need, or will is another CNA expected to attend?
The CNA would be expected to attend. The cultural expectations, though, are that if a resident has a need, anybody will fulfill it. So the med aid would be expected to, within, dependent on where they are in their medication pass. I mean, you have to do it appropriately to mind the the steps of medication administration, do it appropriately. But yes, they should also attend to that resident right away, as would a nurse, as would payroll.
And my next question, the annual activities that you have for your med aid, can you share a little bit about that?
Yeah, so we stage the a skills blitz is what it's called in our facility. I think it's called that a lot of places, where we stage a resident room and have a variety of mock orders drawn up. And that medication aid is to administer those medications to a mock resident who tends to be an administrative nurse of ours, who can then assess that and deem it appropriate or not and provide any education. That's an annual checkoff that we do.
Is there like a time frame? Is it like 4 hour, 8 hour, just a one scenario type training?
It is typically a single medication administration. So we would have anywhere between 5 to 10 medications that must be appropriately administered to this person. It's a one-time thing because we've got a lot of people to do in a short amount of time. Our requirement is an annual skills checkoff. There's no time allotment to it.
There are no additional questions. Thank you so much.
Great. Thank you. I appreciate the opportunity.
And I'll recognize Stacy to introduce our next speaker.
Our next speaker had a schedule change at the last minute and was not able to be here in person, but she is joining us virtually. Just look into the control room to see confirmation that she's available. Yep, okay. So our next speaker is Laura Patrick. She is the interim nursing home administrator with the Alliance Health Group. So Laura, see you on the screen. If you'll turn on your camera and unmute yourself and you can introduce yourself further and provide your comment. Welcome.
Thank you, thank you. Good morning, everybody. I am a permanent interim for Alliance Health Group, which sounds kind of crazy, but so once there's an administrator that leaves a building, I go in and try to get culture reestablished and get things back on track. And then once that they think that that's happened, then they start interviewing an administrator to come in and be permanent. I've been an administrator for, it'll be 2 years next month. And then I hope to be a preceptor at that time. Med aids have helped us out a lot in the last little bit in the shortage of nursing, because everybody knows that healthcare is just going crazy lately. And some of the competencies that I like to have for my med techs is that they are med aids, are that they can multitask, that they effectively communicate both in person, verbally, and on paper. And I like for them to be very detail oriented. I also like for them to have a willingness. I didn't really put this on here, but I like for them to have a willingness to help in whatever area they can. In my building, I try to make sure leadership and all of nursing, if you can do something, if it's in your scope, I like to make sure that you are practicing doing everything optimally that you can to help a resident, because you know, I'm not clinical, but I can pass water. I can, you know, take out trash. I can clean up, that kind of thing. So I like to lead by example and have my leadership team do that as well. Ongoing challenges, we have a lot of issues with time management. So the issue with time management for not just CMAs and CNAs and med aids and med techs, it's not they don't know what to do with themselves sometimes. Like they pass the medicine and then they think that's all they're supposed to do. And I know the previous administrator mentioned that too, but the expectation in our building is if you accept a CMA position and you know you have to have the CNA certification prior to getting the CMA, the expectation for my building is that if you're able to help, you help on the halls. If that means giving a shower, if that means feeding someone, if that means changing someone, you know, we're all supposed to be a team here and we're supposed to work together. Role recognition. There are times where some people that have the med aid, they believe that they're basically a nurse, and some of them will take liberties that they shouldn't until you address it. And the biggest concern for me is safety for a resident. They're not supposed to administer insulin, and I've caught a few CMAs doing that. And of course, they're suspended, and we talk about what they're not supposed to be doing. And then there's a talk with the nurse, because it's, did you authorize them to do that in your place? Because you shouldn't be doing that. Training, like the previous administrator mentioned, it's hard for me as an administrator, knowing how much I had to go through to get my license. It's hard for me with the med aids to understand how they can be put in charge of all kinds of things, pain medicine, diabetic medicine, all this stuff. And they have clinical knowledge based on their CNA, but CNA is still, it's a certificate too, versus, you know, it's not a very lengthy training, and experience does go a long way, but it's still a little bit scary for me sometimes. Ongoing challenges, patient and family understanding of what a medication administration process looks like. A lot of residents and family think that if the doctor says you're supposed to take the medicine at 8 o'clock, you're supposed to take it at 8 o'clock regardless. And trying to help the family and the patient realize that, hey, this isn't like the hospital where they only have 4 or 5 patients. This is, they may potentially have 15 patients, and they're trying, some people have a litany of medicine and some people only have 1 or 2. And so trying to get people to realize that there is an hour before and an hour after that you can administer the medicine. Training versus real life. I think a lot of people get the med aid thinking that, oh, this is going to be a great job, but then they lose confidence in themselves. Like if they make a mistake or if the state comes in and they observe a med pass and something odd happens, and then they lose confidence and they don't want to do the med aid job anymore. That's a problem. And then there's nurses that don't want to supervise them. They don't want to put their license on the line. I've heard it many times. I will supervise this one, but not this one. This one's better than this one. And it becomes like this ongoing battle. And there's also the fear of med errors, especially if you have, residents aren't always understanding of the fact that you have to get this medicine to someone and you have to get them to take it. And sometimes you have to give it to them with a spoon and you can't interrupt that process. And they might need something as simple as, they want a snack or something like that. And that causes a med error, then sometimes they're a little to the cart.
Thank you, Ms. Patrick.
Yeah.
Are there any questions for Ms. Patrick? So, Ms. Patrick, I have a few questions. So
Okay.
you have, in addition to your nurses, your RNs and LPNs, you have medication aides, and then did you say CMA?
Yeah, that's a certified med aid. And then we have, I don't think we have med techs anymore, but that used to be the old school name for a med aid.
So the certified med aid and the med aid, that's like one category of, okay, so used interchangeably. Okay.
Mhm.
When they exceed, you mentioned exceeding their scope and they are suspended, is that information shared like with an outside organization?
I'm not sure about that because we send that to HR and then HR tells us where to go from there. And we don't have, in our facility, we don't have in-house HR, so we have to send everything to a corporate HR team and then they make the decision about what they're going to do. I've only seen this happen like maybe twice. And it was someone thought that they misunderstood that Ozempic and those types of GLPs they're not technically insulin, but they are insulin. It's kind of crazy. So that's usually where things get confused is people don't think that's insulin, but it kind of is insulin. So that's the only time I've seen that.
And so on that note, are your CMAs able to administer sub-Q injections?
We don't allow that here.
Questions? Thank you so much, Ms. Patrick.
Sure.
I appreciate you. Appreciate your time.
Thank you.
Right, and we will continue with our third speaker. I'll turn it back over to Stacy.
Right, thank you. So our third speaker is Ms. Vicki Mason Burgess. She is the Director of Nursing at Glenair. Ms. Burgess, I'll ask you to come to the table. Ms. is a registered nurse with a Bachelor of Science in Nursing from the University of North Carolina at Chapel Hill. She currently serves as the Director of Nursing at Glenair, which is a life plan community, also known as a continuing care retirement community located in Cary. Vicki brings extensive experience as a nurse consultant in long-term care across multiple states, including Florida, Georgia, West Virginia, Virginia, and has a background in cardiac intensive. She has worked in both nonprofit and for-profit organizations and is passionate about providing high-quality care and fostering supportive, strong teams to ensure residents receive the best possible care. Welcome.
Thank you. Thank you for the introduction. As we know, the workforce and the landscape of healthcare is forever changing, continues to change. Medication aids on with Glenair. And also I'll share with you that we are a life plan community. And what that looks like is there's 3 levels of care. That's independent living, assisted living, and skilled nursing. When the medication aid hires on, they hire on most times with limited training. Because of that limited training, a lot of times they don't understand the role. They don't understand their role or responsibilities of a medication aid, which what tasks are permitted, which tasks are not permitted. So we spend quite a bit of time explaining what their role is, especially if they've moved from a different state and they may be known as a CMT or CMA, just lots of different terminology. So therefore, we take that time or that's really needed to understand what they can and cannot do. Also, there's the basic pharmacology, medication terminology. What are medication administration? What are those terms? What do those terms mean? PRN, routes, timing. As the previous speakers have already mentioned, the 6 rights. Right resident, right medication, right dose, right time, right route, right documentation. Also, a good bit of time is spent in making sure the med aid knows when to notify a nurse. If you have to give pause or thought, that's the time to stop and notify a nurse. With our medication aids, we currently use them in our assisted living, not in skilled. In order to maintain consistency throughout the continuum, just in case we do need to utilize medication aids in the skill setting, we follow the guidelines of the North Carolina Board of Nursing, where they are on that healthcare personnel registry. Also, something that's really essential is knowing the rights of a residence, the confidentiality, infection control practices, that is hand hygiene, glove use, safe disposal, prevention of cross-contamination, how to chart medications, how to chart when a resident chooses not to, or maybe sometimes people say refused a medication, if a medication is omitted. Also, safe medication administration by route, oral, topical, inhaled, eye, ear. Recognizing the components of a complete medication order. When maybe the route is not noted on the order, being able to recognize that. Some medications may be given, maybe a oil can be given via the mouth or either the ear. And if that's not documented on that order, knowing when to stop and clarify. Recognizing swallowing difficulties, avoiding distractions, and the ability to effectively communicate with a licensed nurse when there is an error or a question. So those are some things that are essential prior to starting the medication task. Those things are needed. in terms of how our facility ensures ongoing support and supervision for medication aids after the initial training. There is a nurse that is on duty with the medication aid for every shift. The LPN or the RN oversees the performance of the medication aid every shift and is available for questions and guidance. This comes into play really, really important when there's a PRN that must be given. The nurse has to be available for those PRNs. We also do a monthly medication administration skills checklist, and there's an annual medication administration skills validation form as well. And also we use what we call Relias. It's a learning platform. Some of the biggest challenges medication aids face, I spoke with the medication aids. And one of the main things that they mention is coming into a setting, they feel anxiety. There's some nervousness there. So managing that workload to ensure medications are given in a timely manner. So in alignment with our commitment at Glenair to culture change and resident-directed care, we utilize what we call block scheduling for medication administration times. And this also maintain a smaller resident to medication aid ratio. So this has effectively minimized this challenge. And it also support of the nurse to assist with managing the workload. The nurse assists with managing the workload if needed. Also, interruptions and multitasking. During our orientation or shadowing process, the nurse training asks the medication aid, what could we have done better? We do real life scenarios or situation. If is not to take a medication, at that time, the nurse will ask the medication aid, what would you do? What should we do? Also, in recognition of when to stop and ask the nurse. The nurse encourages the medication aid to ask questions freely. Stop the process if you are uncertain. So these are some of the biggest challenges that are coming from the medication aids themselves.
Thank you, Ms. Mason Burgess. Are there any questions?
Yes, I'm curious, you said that you use medication aids in the assisted living
Yes.
and not skilled.
Yes.
Can you kind of share why that's the case? Just curious.
I'd like to introduce to you all Erica Richardson. She is our staff development coordinator.
And just to add, just to quickly introduce myself, I'm at Glenair. I do staff development, as well as infection control. And I myself used to be a med aid. So that was part of it. I'm kind of a frontline employee at Glenair, and assisting with the hiring process. So just thought I'd help Ms. Burgess here with some of the questions. As I am like frontline, I'm there helping training, asking questions, and have done the role myself. So with that, yeah, we like to utilize them in our assisted living. It kind of goes in line with the certifications that they have. When we looked at one of them, one of the med aid certifications, they are in an adult care home as opposed to the ones that work in nursing homes. So this helps us. We do use the higher level of certification that can work in the nursing home. We feel that safe practices, comfort, that ability to pass the medications is greater utilized in assisted living facilities. These type of residents, we call them residents there, they're one step from self-administration. They're there to get help. So this way we put them in a position where they feel more comfortable. There's not as many PRNs. They have the nurse working with them. So we do utilize them in our assisted living because it's not just a level of comfort, but it kind of helps eliminate a lot of those higher skills that nurses are needed to have that med aids may not have. So that's why we choose to do that.
Thank you for that delineation. And then, you said that an RN is assigned to each shift or something.
Yep,
for the
RN or
medic-
LPN.
Yes.
Are they on site or
Yes,
they
yes.
available on site? Okay.
Available at all times. In our setting, our med aids have great support. They don't just have a nurse there with them on their floor like a charge nurse. We also have nurse mentors at Glenair, which is they're called mentors. And then another resource, I'm a building and our director of nursing as well. So we have 4 levels in our facility. Unlike med aids that work in the adult care homes, they may have one nurse on site. I think you addressed that at the last meeting, or may not have a licensed nurse on site. So in our facility, we have great resources, which I think is a good practice to have. So
Thank you. And I think my last question, when looking at the partnership, the medication aid, the RN, and the patient, who is or how is the patient around the medication being done? So, as a registered nurse, I'm administering medication. I'm saying, here's your Coumadin. This is what it's for here. We do patient teaching or patient education about the medication. What's the workflow of that in your setting with the medication aid in that process?
sure, I think it's ongoing educational process. The front line again would be that med aid because part of their training is to know medications, know what reactions are, know what the med is used for. So that frontline education is the med aid because it's required on their checklist that they know their medications. But again, the resident has that right to say, I'm not too clear, and then that nurse is there for the backup. And as well as a provider. At Glennar, I forgot to mention too that we do have a nurse practitioner on site, and we have a medical director as well. So that education is ongoing, but the frontline is expected to be the med aid.
I've got a question. You said, are there 2 levels of med aids? Because you said the high.
Yeah, so just reiterating what was addressed here at the meeting, types of, there's the adult care home med aid, and then there's the med aid that can pass meds in other facilities, like in nursing homes. So there's a nursing home versus adult care home. We choose to use the one that, even though we do have assisted living and we probably could utilize the adult care home med aid, we choose to utilize the nursing home med aid.
Thank you.
Just to maintain that consistency, in case we do use them in our long-term care setting, in the skilled facility setting.
And so my question, kind of on that same note, in terms of PRNs. So when the med aid is to administer PRN and the nurse is available, has to be available, who pulls the PRN? Does the nurse pull it and administer, or does the med aid pull and administer?
So I think it varies, and I would say that because I've seen orders when working in adult care homes or assisted living facilities, the order can be written for pain reported as a 1, administer 1 pill, for pain reported as a 4, administer 2 pills. So that doesn't require the assessment piece. But if the assessment piece is required, it's just written as a straight PRN for pain, then a nurse would do the administration.
And that is correct. So the nurse is pulling that.
Additional questions? Well, thank y'all so much for your time and for sharing. And so now Stacy will provide a summary of written comments from other representatives.
Thank you. And I just want to say thank you again, guys, for coming to the board. Thank you so much. So we did receive written comments from other representatives. They're provided in your meeting book under agenda item 6D, beginning on page 24 of the meeting book. The document there provides verbatim comments that were provided by 1 med aid instructor, 2 other directors of nursing, and 1 director of compliance and risk in the nursing home setting. So the comments will now be summarized for the consideration of the committee. So we've heard from more than one speaker, and also in the written comments that we received, that there is role confusion between the med aid and the med tech, not just from the people doing the work, but also from the nurses that are delegating, from in the training as well. Another key point are that the essential competencies were mentioned more than once do include multitasking, being able to effectively communicate, accuracy in reading the infection prevention concepts, blood glucose checks, and what and when to report in addition to documentation. Also, the amount of facility support that is needed in addition to completing the curriculum. So you've heard from our guest today, as well as in the written comment, a level of training that has to take place once the man becomes employed. So there's additional training that the facilities are needing to do. Most mention annual skills check by an RN, mention periodic audits just to check competency of the medication aid. Transition challenges, we heard more than once that there currently is not a clinical component curriculum, and most mentioned the benefit that that could potentially have, as well as needing more practice to develop the confidence and the time management of a complex med pass for a hall of a nursing home when medication. So being able to practice the training rather than having, to be kind of thrown into that on employment. So a few comments that we received by these written comments. Dr. Kimberly Delgado, who is a long-term care nurse educator, also submitted comments for consideration. She was not able to attend today due to a prior obligation, but was very delighted to provide comments. Her verbatim comments are provided on pages 9 of the meeting book, but I'll just provide a summary for the purposes of the meeting. Dr. Delgado's comments describe the challenges of medication aids in the areas of effective communication and time management after complete training. An expectation to participate in NA1 tasks during medication administration is also reported as a challenge in self-advocacy and prioritization of patient safety. She makes several recommendations, such as increase the required number of hours, the infection control standards and route-specific administration information, and maybe add a 7th right administration to be the indication of the medication, why the client is receiving that medicine. Add instruction on the use of an medication record or the electronic health record. Add instruction on topics of cultural competence and health literacy. Topics were that she mentioned as being added as a new hire and annual training. She talked about what to report related to polypharmacy and antibiotic stewardship as part of their onboard management and prevention of med errors and effective communication. Other recommendations she made related to audits and data. So recommending audit training programs for compliance, ongoing professional development for training faculty, formal instructor evaluation by students and peers, an expansion of faculty requirements, data related to reporting rates, and providing opportunity for long-term care organizations and med aids to give feedback to inform the curriculum updates. Recommended the consideration of expanding the knowledge base of monitor for adverse effects. However, our current rule reserves this activity for the licensed nurse and does not allow delegation to monitor adverse effects. So this concludes the information provided by representatives.
Thank you, Stacy. Are there questions related to the summary or the? I found them very interesting. I appreciate the feedback. I think also we learned some of the discrepancies. I found it interesting to see like 6 rights, and then some said 5 rights, and now there's yet a 7th right. And I like that 7th component actually, but let us know that in addition to the med aids, trainers need some training for consistent. Any other?
And I guess I would add that also my reflection is that the agencies or the organizations need infrastructure to be
Yes.
able to maintain these medication aids. I mean, we're educating them, they're getting certified, they're getting hired, but it's everybody is approaching it in and they need that training and support, and that requires infrastructure.
Absolutely, Dr. Shaw. I thought also like the practicum, the hands-on component. And so you think about our CNAs and they go and they take the written exam, the hands-on. And then for medication, you know, that's major. I know I've said this before with medication, period, as an educator, pharmacology, one of the toughest courses in a nursing curriculum. I know Dr. Kistler understands this as well. All of us do. How, you know, that class, students don't always do so well. And yet we have a couple hours where to have this knowledge and know these different classifications and then go and administer these meds in a timely manner and then do all the other things that are required. So just interesting. Just this whole process is very informative, and so I look forward to us matriculating through to see what our outcomes need to be. If there are additional questions or comments, absolutely, yes, Dr. Tillman.
Thank you, Madam Chair. I would just like to comment under what Dr. Delgado said about psychopharmacology in older adults. That is huge. You know, I think that kids have to know that typically older patients are going to get about half the dose and the impact that that can have. And elderly adults, when they get a urinary tract infection, it can cause confusion. And just having that knowledge between, okay, I need to go to the nurse and say, wow, I've got confusion. Is it because of the treatment I'm given or is it because of UTI? You know, and I think that's just comes with practice and being around. But I think psychopharmacology, and you could probably spend 3 days alone just on that. But that's just my comments. Thank you.
Yes, absolutely, Dr. Tillman. Next, one of our presenters today about the data, is their data. And, you know, I think about some of the information that we encounter, that we come across, or that's, you know, that data in terms of this group, medication aids, some of the same mistakes that come to us from our practice. Just be good to know, you know, in terms of what else do we need to do, what's not being addressed. So there are no additional comments or questions at this time. We will take a 10-minute break and come back at approximately 10:40. My math right? Thank you. The meeting of the Education and Practice Committee. I will now recognize Dr. Jenna Caparel to provide information related to the survey of medication aid instructors.
Thank you, Madam Chair. One of the directions for staff following the August meeting was to create a survey to gather feedback from RN instructors and master teachers regarding medication aid training programs. The survey, which was provided to you all in the packet starting on page 30, includes demographic questions as well as questions related to any challenges or opportunities for improvement they identified from their RN instructor and master teacher roles. The goal of the survey was to obtain information to help the committee determine if the medication aid training aligns with the North Carolina Board of Nursing regulatory standards and real-world practice needs. The survey was sent to 301 instructors and 14 master teachers. As you can see from the slide, we had 165 RN instructors respond, which was approximately a 55%, and 3 master teacher responses, 1% response rate. As is evident, the majority of respondents were RN instructors. We did have a higher response rate from Eastern North Carolina with about 52%, and then with Western and Central North Carolina being equally represented. For the medication aid instruction setting, almost half of the medication aid instruction was provided at the community college, with approximately a quarter provided within the nursing home themselves. The vast majority of medication aid students in these programs worked as nursing aides in nursing homes, a little over 7%. So as I mentioned, we sought feedback from the RN instructors and master teachers regarding any challenges they identified in their instructor-teacher roles. Specifically, we asked for feedback regarding any challenge in offering medication aid courses to students and any challenges encountered in providing the board-approved curriculum. Of the 168 respondents, approximately 80% provided written feedback on the challenges they encounter and common challenges they identified. As you can see, half responded that the education material was outdated. Following that was a lack of interest that included no-shows to the courses or not enough interest in the. The third most common challenge identified that there are not enough master teacher programs. This was identified by RNs who indicated the interest in becoming master teachers because there were not enough RN instructors available to teach medication aids where they were located. We found when reviewing the feedback that the request to become a master teacher was often directly related to the shortage barrier to instructor. Other challenges included time limitations, so the course not being long enough, followed by those that stated the course was too long. So from the feedback, it appears that class size influenced whether there was or too much time to teach. Additionally, included in your packet starting on page 34, but not in the PowerPoint presentation itself, we sought specific RN instructors currently teaching medication aids to help provide clarity to some of the challenge responses we received. With a random sampling of 12 RN instructors back from 4 of them, and their feedback is provided in its entirety. The questions we included were very similar to the ones we asked the speakers today. What competencies or clinical skills do they consider essential for medication aids before they perform the technical task of medication administration in long-term care? What is the biggest challenge medication aids face when transitioning from classroom training to real-world medication administration? And how do you help them overcome those? How does the provided training support the medication aid transition to medication administration in long-term care? When we looked at the 4 responses from the RN instructors combined with the survey results, there was a common theme identified outside in the graph, which was a consistent lack of clarity in the role of both the RN instructors and the medication aid students. We will touch on more specifics as it relates to limitations of the medication aid role, as well as instructors' knowledge of the medication aid role, leads to confusion. Examples include students do not understand in what setting they can work. Students and instructors lack knowledge of the difference between medication aids versus medication techs. RN instructors asking Board of Nursing to expand the role of the medication aid. And both RN instructors and medication aides lack understanding of the technical task of medication administration. So a summary of the key points within the survey section here is that the survey did represent board-approved nursing instructors as well as master teachers. The curriculum is not up to date with the current clinical practice standards, and role confusion exists among both students and faculty. And that concludes the survey review portion of this presentation.
Thank you so much, Dr. Caporal. Are there any questions for Dr. Caporal?
I just had one question. I heard you say it, then I read it, and I'm still, I can read, so therefore I know exactly what it says, but the meaning or the implication behind it seems startling. So it says both RN instructors and medication aides lack understanding of the technical task of medication administration.
Mhm.
So those who are teaching it don't know, and those who are receiving the instruction don't know.
Mhm.
And so the Board of Nursing is being asked to clarify both, for both.
So what we're finding is that when we ask for the feedback, what they're identifying is not something that really currently falls within what the medication aid does. So for example, we had addressed earlier pharmacology training and education, which that is not currently what is within the medication aid curriculum as it stands. And so understanding where their scope, if you will, starts and ends with the RN instructor, asking for that education for them, asking for that clarity is where we're finding that that role clarity isn't clear for both parties.
And so because we have also a deficit in those who can teach these students, right? It appears that when you don't KNOW, you say NO. So therefore, if the teachers or the instructors are not constantly, but if they are saying we don't have a ready working knowledge of the curriculum or what we should be teaching or the current standard of practice for medication aids, then that could be the reason why we also don't have instructors who are ready, willing, and able to teach the medication aids. I'm just trying to put it all together. So is
Yeah.
that your assessment as well? Or what is your assessment?
Oh, sorry.
Let
I'm
me
gonna
start there.
pivot to Stacy here.
Okay.
So the current curriculum, I have it over here if you guys want to take a look at it. There's a student manual and there's an instructor manual. And it's basically a script of what the instructor is to say in order to teach the material. Okay, so it's not that the instructor doesn't know what to teach. The gap that we're seeing more definitively is the content of the curriculum is not up to date. So the curriculum was developed when this initial work was done as a collaboration, right? But the legislation that was specific to med aids in nursing homes didn't become effective until 2006. Okay, so the gap really is the content of the curriculum, and then the curriculum would then reinforce with the instructor where these med aids can work and what activities they can perform. So the gap is more with the curriculum. That's kind of the root of the knowledge gap. Does that make sense?
It makes sense. I have so many other questions that are probably not necessary right now. So
Okay.
I'll pause. Thank you.
Any other questions? All right, so we will now turn it back to Dr. Caporal for information on the curriculum review.
Thank you, Madam Chair. I think some of those questions will also be answered in this curriculum review section. So after reviewing the survey results with the outdated curriculum being the primary area identified as a challenge for the RN instructors, board staff review the curriculum as it is currently available. As Stacy mentioned previously, but the items included for the instructors include the instructor manual that was last revised in 2010, the DVD, which is a 70-minute video to reinforce the manual, a toolbox supply information, which was revised in 2017, and a paper medication administration record. So while the curriculum was last updated in 2010, the initial curriculum was developed about 5 years prior to that. Much of the material referenced dates back to the late 1990s to 2005. The curriculum does not address electronic medical or medication administration records, focusing solely on paper-based documentation. Many of the links and references are no longer active, and the supplemental material is provided in DVD format only. As a matter of fact, in a part of the curriculum, it actually references VHS tapes as well. So for example, the Institute for Safe Medication Practices, or the ISMP, recommends medical abbreviations that are safe in current practice. The most recent one in the curriculum dates back to 2003, where we know that there's, I believe it was just updated last year. So we know that there's more recent ones available. The Do Not Crush medication list is also out to date. Material references include 5 rights of medication administration versus the 6. So those were used interchangeably in the curriculum. And then the vendor list provides contacts and locations for businesses that are no longer in business or have relocated. So at the time of the initial creation of the curriculum, there was no clear delineation of where medication aides trained by RN instructors through the Board of Nursing could be employed. Multiple employment settings were addressed in the curriculum, including different populations, such as infants and children, which leads to the confusion of where medication aides who completed this training can work within today's regulatory rules. It is not clear nor specific to the nursing home setting. And so a curriculum review, the 3 key findings from the curriculum review, is 1, there's a need for modernization. Since we know that the curriculum is outdated, this affects relevance and accuracy specifically to medication safety and documentation practices. We know that there's a delegation and setting misalignment. The curriculum includes pediatric content and general medication aid rules across various settings, but does not specify the nursing home setting. And then the technological and resource gaps, where we find that non-functional website links and outdated vendor material and resources can hinder access to supplemental materials. And then additionally, the lack of an electronic medical record integration into the curriculum may inhibit the medication aide's readiness for practice in the current healthcare space. So in summary, feedback from RN instructors and master teachers revealed several key challenges in offering medication aid courses and implementing board-approved curriculum. A review of the curriculum confirmed these concerns. Opportunities exist for clearer role definitions for both RN instructors and medication aides, as well as opportunities for curriculum modernization. And so this concludes the curriculum review portion of the presentation.
Thank you, Dr. Caporal. Are there any questions related to the curriculum review? Yes, please.
All right, so thank you for this. And, you know, my comments are centered in an education background, so, and a curriculum specialist background, actually. So I guess the first question is, since the Board of Nursing owns this curriculum, right? Because it says NCBON curriculum for medication aids. So I just want to clarify. Okay, so since we own the curriculum, when we are tasked with updating any curriculum, what are the kind of initial steps that take place just for that one portion? So even in the recommendations, it says to review and revise the med aid curriculum number 3. What are the, what's kind of the timeline, or how do we go about updating a curriculum?
That will be, I will include Stacy in this response.
So there could be several, it could be that the staff research, what other states have in place. It could be, exploring the literature a little more to see if there are any new standards out there for this particular role. It could be that the committee desires for a group of subject matter experts come together as a collaboration to revise the curriculum. So there are a lot of different options to consider for the committee to decide how you would like to move forward.
What would be the most efficient for you all if you had to select? Because this is essentially a curriculum overhaul. Because, let's just call it early 2000s to now 2025, really 26. But we need to be thinking about 2030 and 2035. So this is essentially 30 years worth of thinking and thought process. So what would be the most efficient for you if you had your magic wand to say, this is how I'd like to see the curriculum updated? Because we could use those traditional methods or strategies to update, but we also could just kind of jump to the end.
Yeah. You know, if you're asking me what I would prefer.
That's exactly what I'm
um,
asking.
Yeah, I think it would be good to allow staff the opportunity to research what other states do,
Mhm.
to see, to bring together the best of the best,
Yes.
and then couple that with validation from subject matter experts
Yes.
that this is, the way to go.
I concur. I think it's very efficient and mindful, a mindful use of the staff's time to be able to go and explore what other states are doing and see who's doing it best and who's doing it well and who's proud of what they're doing. Bring all of that back together and then have the staff review and then maybe get a few instructors who teach the curriculum to come in and look at the curriculum and just examine it and see if it can work in a practical way for what we do in North Carolina. And then from there, have the SMEs come and, or assess and then, consider adopting from there. So I do highly recommend that approach as well. So the other thing I would say is so the faculty requirements, it says that they are currently strict, and we talked about this in the August meeting. Is there any thought around loosening the faculty requirements for those who are able to teach the curriculum? And the thought is this, that if a teacher knows how to teach, the teacher can teach a lot of things, not just one thing or two things. So is there any thought around loosening the restrictions of those who are certified, qualified, and able to teach the Med-Aid curriculum?
So if we look at the standards that we've compared our current rule to, um, leaning more toward, teaching is a component of practice for the registered nurse, right? And that is a part of the initial education of a nurse. That is like, a core competency for a registered nurse. So, part of allowing an RN to work at the top of their license is, enabling them to be able to um, contribute to the curriculum in a particular location that is focused on this setting. So, is there value in requiring our instructor to renew that certification, so to speak, every 2 years? What is being done in that period of time that really warrants that renewal? That's the big piece that we currently have in place that's not in other models.
Mhm.
Once in other models that we've looked at, once you're approved, you're approved. And you don't renew that certification, but you participate in continued learning in that particular area, which is also a part of maintaining continuing competence to maintain licensure. So, this is not different from a registered nurse teaching in other areas,
Mhm.
but we currently require an extra step for them to continue to do this. So making it more lenient in that respect would potentially, open that up to people having it, being approved, and
Right.
just being able to provide that education. Does that make
Right.
sense?
Oh, yeah, because that is currently a restriction. So
Right.
loosening that restriction could absolutely unclog kind of this pipeline issue of instructors or people who are willing to go through the process. So thank you for that. Did you have a?
I was just going to say in regards to the certification piece, I think there's some confusion regarding that as well, because it's just us approving that individual. We're not giving them like a certification to be able to go out and provide this service. So I think that's something to clarify as well.
Yeah.
When you think of a certification, you're thinking of a nurse going and sitting for a national exam. They're not doing that. They're just receiving an approval from us indicating that they're able to provide this service.
Right. And I think that is true because when you get into the field of any profession and people start talking and they say things like, well, I did X to get my certification, and then that passes on to other people, then they start to believe that that is the standard as opposed to looking up what is the standard and what is required. So I think it is, definitely, it will be beneficial to clarify what is required and what is not required. and maybe issue a memo to all nurses in the whole state that, this is when we issue our white paper or our memo or our position statement, which I see there is a request and a suggestion to revise and revisit that. But when we issue that, it doesn't hurt to explicitly say, this is this and that is that. And then for rules, as it relates to the draft rule, will we have to go through another rulemaking process for all of this? Okay,
That would be correct. Dr. Steele?
well, that's just wonderful. Thank you. I have no further questions.
Questions or comments? And so my comment, on that same note, that Dr. Steele mentioned about the instructor training. So if we allow the RN who does, have that background in terms of teaching or that experience or educating, once they complete an instructor training course approved by the Board of Nursing, then I'm just concerned about if we take some of the restrictions. I agree that we shouldn't have too many that hinders, but what will we have them do? And I guess this is rhetorical, to make certain that they maintain the standards, the information. So for instance, if we have someone complete the instructor training and then it's 5 years and, we are on it and, we're not going to let it be 2030 or 2070 and we haven't, done anything in terms of the curriculum, but how will we make certain that that instructor, if he or she is still living, is able to maintain the standards?
So that would be up for discussion, and it could be something in rule as the committee decides as to how that will be monitored. I can tell you from the NA2 courses, we require them to complete information for an annual report that gives information on how often they've provided the training and how many students they have trained. That's not currently a part of the Med-Aid, but that's a way to monitor how often they're providing the instruction, therefore how current their knowledge is.
I was going to ask that exact same question. What are they required to do otherwise? So this is not the only thing that they teach or type of course they teach. Med-Aid, they teach other things. So what are the requirements? I think the consistency is key. So if they're teaching, if there are 16 opportunities to teach things and Med-Aid is one of those things, then what are they required to do for the other 15 that makes Med-Aid so different? Or should we make Med-Aid comply with the others? That's kind of certifications. In other professions here in the States, sometimes people are required to take like an ethics training every 3 years, but renew their license every year and confirm they have 8 hours of continuing ed every year annually, but every 3 years. So they have an additional, thing every 3 years, they have to take something else. So there's that model, but then there's a model in nursing that maybe, like you said, they just kind of sign off on what they've done. Another option could be that the Board of Nursing, I don't know if this is even done or can be done, but we provide some type of refresher. And the refresher is an hour. You mentioned the DVDs and the VHS. The refresher is some type of online, media component. And maybe in the research, you'll find something that is a refresher Med-Aid instructor, video or some type of, asynchronous video with questions and things like that that are necessary to be completed prior to teaching a class. And then it could be a recommendation, like we recommend you watch this before you teach this course, especially if you hadn't taught it in 2 years or more or something like that. And maybe we create that, or we task someone with creating it, like an online instructional body, and we hire them to actually create it and make it available in our library of instructor materials. But that's a way to overcome the barrier of consistent continuing ed for teachers or instructors who need specific instruction before they teach a course. And then whomever is teaching these courses. So help me understand, if there are med aides who say in North Carolina, I want to be a med aide, where would they go to get instruction? Is that a community college? Is that one of the nursing schools that we've approved? Is that online? Where would they go?
So currently, we approve the instructor. So that approved instructor can take the curriculum anywhere they want. They can go to a long-term care facility, they can be employed by a community college, they can have a contract with a certain vendor where they go to different, I mean, they can do it anywhere. So, and the board doesn't approve where they're teaching, they're just approving this RN can provide this instruction.
Is that consistent with
So-
all RN available courses to teach? No, right? Most of them
So
are housed
for-
like in places.
So the point of comparison that I have is the NA2 courses.
Nurse
okay?
aide too.
Yes, the nurse aid 2. So for the nurse aid 2 courses, it's the actual course that is approved using 12 modules for the specific tasks that are involved in that level. So the course has to meet faculty requirements, objective requirements, hour requirements, clinical requirements, ratio requirements. So there's a whole list of requirements for the course that includes faculty requirements. But that's for the entire course to happen at a certain location that is approved. So that's not one that can just happen anywhere. We know where that instruction is happening because it's only approved for that location.
So what kind of course compares to med aid? Just NA2?
Yes.
So that means that it's actually not held to the same standard as NA2,
Correct.
which means that
Currently
this is why
not.
we have everything that we've reviewed today.
Correct.
So I'm gonna let Dr. Kistler, I'll rest a minute, but I wanna come back.
So the thing that my faculty talk about when we talk about med aid is it seems more aligned with the American Heart Association BLS or ACLS, where you get approved for course content. And then we require them to do updated training because they are employed with us. But you guys approve them and then they can teach it kind of wherever within any of our facilities, whether it's Alexander campus, our Goodwill location, or our main campus. So they talk more along the lines of like a BLS training and teaching, and where in that it's portable. And it does not quite align with the way the NA1 training and teaching and approvals and the NA2. So most of our NA1 and NA2 instructors also teach med aid, and it's just a little bit different. And that's one of the things we tend to clarify.
So I just want to clarify, this is from a public member. It sounds like people are being taught, professional people are being taught to give me and my friends medications in a very short amount of time. And they're making errors and just different things, or they're not making errors. They're doing a great job. Either way, we don't know what we're going to get. And I saw one of the lit reviews say that under a particular pilot where med aids were introduced, the errors went down from RNs and LPNs. The errors went down. So the sample size that was tested in this particular pilot, when those errors went down, that was because there were qualified, certified, educated med aids introduced to the practice in that particular clinical setting. So going back to what I was saying earlier, it appears that people are being taught to do a very serious thing in a not so managed way, or in a not so serious way. And I'm trying to find my words, but in a way that is not held to the same standard as something like nurse aid and NA2. But if we have nurses who come before us for discipline because they've done something with the medication, we take that very seriously. And we discipline very, intensely, I would say, because of those different, cases that come before us. So it seems to me that our task is really to elevate the practice of med aids so that maybe we address some of these concerns, and elevate the practice in general of nursing as the med aids. Because if we treat it flippantly, not that we're trying to, but if we treat it flippantly with the curriculum, with the modification of the curriculum, with the instructor status and how to become an instructor, but say, oh, it's more strict because you can't, do it unless you certify, every so many years, whatever. But it's the least sound on the curriculum side for being up to date and things like that. It's the least sound of all of the curricula in nursing. We're talking out of two sides of our brains. We're saying it means a lot, but it doesn't mean as much. Just by the paperwork, not the way we feel. I'm talking purely paperwork. And then when we heard from the folks who presented to us today, and then those who sent in statements, everyone's aligned that something's wrong, right? And I think something's wrong because we're not like the standard of the med aid curriculum, the standard of the teacher, everything is just not at the highest level of where it could be. So the task on us is really to elevate the level of a med aid and how we perceive their service and then their training and then the training of the instructors who teach them as well. But then also I still agree with eliminating the barrier that, if these registered nurses are strict courses with less restrictions, then why do we make this one so strict? But then the curriculum hadn't been updated for almost 30 years. Like it's misaligned. So, yeah, I'll pause.
And just a comment to that, and I think the passage of time has been, the worst enemy for this. I think that the curriculum is detailed and was perfect for when it was created, in the development of this role, because the curriculum was developed before legislation was passed to even allow this group to perform this task. So I think it was very forward thinking, but I think the complexity of care has just climbed so quickly in every setting that it is a challenge to keep up with that current practice. So I think the needs today are different from where the curriculum was developed. And to your point, elevating that role to their full contribution to the client's care is needed.
Yeah, and that's why I think getting to the curriculum modification as fast as possible through looking at other states and just bringing in the SMEs and just getting it done, like, that's the most beneficial thing I think we can do for the curriculum. And then when you said, okay, so now I know what I was also going to say about the individual instructor. When we approve an individual instructor, then we are subject to an instructor's expertise, their willingness to learn the curriculum, their willingness to adhere to the curriculum without any oversight rather, on their standards of instruction. And then also the way they teach the course and how they are held accountable for the students who graduate from the course or who finish the course. And so I think there's something there that we also need to look at as a committee, and whether or not we want to continue certifying just an instructor or certifying the course and where the course is taught. Because essentially what we're saying is NA2 can be taught with 12 modules and approved in these settings. And that's the same thing we do with a lot of courses, right? But then for this particular course, we say any person can teach it that we approve. And when that person teaches it, we now have, 500 schools, because we have 500 licensed people or certified people to teach it. And it produces rogueness in instruction, if you will, to have 500 different ways of instructing when you have curriculum that has a script and, those types of things. And so it's like a perfect storm. The curriculum's outdated. We've got 500 individuals interpreting this outdated curriculum. Maybe some are supplementing, maybe some are bringing in some additional resources that are more current. And then we've got practitioners saying, wait, something's wrong. It's not quite working. We have to limit their scope in the field, or we have a lot of errors, or we have this, or we have that. So, and then we have an instructor pipeline issue. So it's like a perfect storm of a lot of challenges. So I appreciate everything you all have kind of brought to, and I'm glad we pushed this to this meeting to be able to do more research from August. So thank you for the hard work. Time to get busy.
So thank you, Dr. Steele and Dr. Kistler. Also, and this may be a rhetorical question, Dr. Steele made a lot of the comments that or questions that I had, but rhetorically speaking, since the curriculum hasn't been updated for quite some time, is there a reason why it's been so long that we haven't done anything?
I do not have the answer to that question.
Okay, all right. And so just reiterating what Dr. Steele also said, as we matriculate through this process, hopefully we can put something in place so that we won't get here again. Okay. All right. So thank you, board staff, for providing the meeting book and for the informative presentations. Now, provide us with a summary of the pertinent points presented today.
Okay. All right, thank you to everyone who has participated in sharing information with the committee today. We've heard many viewpoints, experiences, challenges, and recommendations that will be helpful in discussing the next steps of this important work. Medication aids in nursing homes play a in allowing licensed nurses to focus on higher level decision-making by performing the technical task of medication administration. In upholding the public safety, the Board of Nursing must ensure medication aid faculty requirements are sufficient to provide ample instruction without barriers to this role within the workforce. All the information provided today lends itself to 5 conclusions for committee discussion. Work is needed. We have some work to do based on the information that's been shared today. Second, role confusion continues amongst faculty, employers, and medication aides. Number 3, the current curriculum is outdated and includes references that do not illustrate current practice. Number 4, the current rule involves strict faculty requirements when compared to other models. And lastly, information is needed by long-term care nurses related to the role of the medication aid in nursing homes, and also the responsibilities of the licensed nurse when delegating medication administration. Conclusions, 5 potential actions are provided for committee consideration in reviewing faculty and training requirements for the role of the specific to nursing homes. First, request an extension of the charge into 2026 to allow time for the needed work. Review and revise the position statement, medication in long-term care and skilled nursing facilities versus other settings for clarity. Another potential step is to review and revise the medication aid curriculum. Revisions for 21 NCAC 36.06. Rules are enforceable, so if the desire of the committee is to require certain things of faculty or training, promulgated so the board can regulate and enforce those requirements. And lastly, potentially develop a plan for information dissemination to nursing homes specifically. Other steps may be identified by the committee to fulfill the purpose and the authority of providing adequate training for medication aids to support medication administration in nursing homes and improve client, resident, and patient outcomes. So this concludes the summary of key points of information shared in today's meeting.
Thank you, Stacy. And so now the committee or committee members, we will begin our process of discussing the role of the medication aid information presented today. This is the opportunity to ask additional questions. I know we've had a lot of discussion already, but if there are additional questions or comments regarding any information that has been provided, this is time for us to have that discussion. So seeing none, I think it was a pretty robust discussion. So I'll move on to the next component, which is summary and recommendations. So we've heard important information and summaries of key themes about the role of medication aid in nursing homes, focusing on the board's jurisdiction of faculty and applicant requirements, education and training materials, and the delegation of medication administration from a licensed nurse, what direction will be provided to staff as next steps of addressing the key points of, and this is what Stacy just went over, additional work needed, role confusion, outdated curriculum, strict faculty requirements, and information needed for long-term care nurses related to delegation and supervision. And so with that, next steps, potential next steps. First, requesting an extension of this charge to November 2026. And in addition to that, directing board staff to review and revise the current position statement, drafting rule revisions to 21 NCAC 36.0406, review and revise curriculum, develop a plan for information dissemination to nurses in nursing homes. And I think in addition to that, role clarity was mentioned. Yes, Dr. Steele.
I move to instruct, I move to accept staff's recommendations for potential actions and next steps, including 1 through 5 as presented today.
Thank you, Dr. Steele. Dr. Steele has moved to approve the direction that was previously indicated to board staff. Is there a second? Seconded by Dr. Shaw. All in favor by show of hands, and it is unanimous, so the motion carries. Our next Education and Practice Committee meeting will be March 4th, 2026. At this point, I need a motion for the meeting to adjourn.
Madam Chair, I move to adjourn today's meeting.
All right, so Dr. Steele has moved to adjourn. Is there a second? It has been seconded by Dr. Kistler. All in favor by show of hands, unanimous. The meeting is now adjourned. Thank you so much, board staff and committee members.